All right, today we're diving into this incredible hidden network of nerves, the one that controls something we barely even think about. But what happens when that network goes haywire? We're talking about a condition called neurogenic bladder, where just one tiny misfire in your body's wiring can lead to a total loss of control.
I mean, really think about it for a second. Going to the bathroom, it's something most of us just do, right? No second thought. But under the hood, it's this super sophisticated conversation happening between your brain and your bladder. So the big question is, what happens when that vital line of communication gets cut or damaged? Let's jump in and find out.
So what is neurogenic bladder exactly? Well, at its core, it's not really a single disease. It's more of a description, a catch-all term for when your lower urinary tract stops working right because of a problem somewhere in your nervous system. And the specific kind of problem you get, that depends entirely on where the damage is.
Okay, to really get a handle on this, we're going to break it down into 4 parts. First up, we'll look at how the whole system is supposed to work, the command center, if you will. Then we'll explore what happens when that communication breaks down. After that, we'll see how doctors figure out exactly where the fault line is. And finally, we'll cover the strategies for restoring control and, just as importantly, quality of life.
All right, let's kick things off with Section 1, the bladder's command center. Because, before we can really understand the breakdown, we have to appreciate just how perfectly the healthy system is designed to work.
Okay, take a look at this. This is basically the body's wiring diagram for your bladder. And what's so wild is just how complex it is, right? You've got nerves coming from all these different parts of the spinal cord, and they all have to work together to control this one little organ. This is definitely not a simple on-off switch. It's a constant, perfectly coordinated conversation happening inside you 24/7.
So the main player here is the autonomic nervous system, and you can think of it as having 2 opposing teams. First, you've got the sympathetic nerves. Their motto is relax and retain. They tell the bladder muscle to chill out so it can fill up with urine, and at the same time, they tell the exit door to stay shut. Then you have the other team, the parasympathetic nerves. They're the contract and expel crew. When it's time to go, they signal the bladder to squeeze and empty.
And this visual shows that coordination perfectly. Over on the left, you see the storage phase. The brain is sending relax signals to the bladder and stay shut signals to the exit. But then, on the right, when it's go time, those signals totally flip. The brain gives the green light, the bladder contracts, and the sphincter, the exit valve, relaxes. It's a perfect synchronized switch.
So that's how it's supposed to work. A beautiful, elegant system. Now let's get into Section 2 and see what happens when the command center itself or its communication lines get damaged.
And this right here is the key takeaway. The location of the damage in the nervous system, what doctors call a lesion, is what predicts the exact type of bladder problem you're going to have. We can pretty much group these into 3 main areas, which you can see on this diagram.
First up, if the damage is way up high in the brain, like from a stroke or in Parkinson's disease, what you lose is voluntary control. The brain basically can't tell the bladder to hold on or wait a minute anymore, so the bladder becomes overactive. It starts contracting whenever it feels like it, leading to that sudden urgency, having to go all the time, and incontinence.
Okay, but what if the damage is lower down, in the spinal cord itself? Think of something like a spinal cord injury or multiple sclerosis. Now things get really complicated. The brain's signals get all scrambled on their way down, and you lose that beautiful coordination between the bladder muscle and the exit valve. And this can lead to a really dangerous situation.
This condition is called detrusor sphincter dyssynergia, or DSD for short. Just look at the comparison here. Normally, the 2 muscles cooperate, right? One squeezes, the other relaxes. But in DSD, they actually fight each other. The bladder muscle contracts, trying its hardest to empty, but the sphincter muscle also contracts at the exact same time, blocking the exit. It's like pushing against a closed door. This creates incredibly high pressure inside the bladder, which is so dangerous because it can back up and seriously damage the kidneys.
And finally, what if the damage is at the very bottom of the line, affecting the final nerves that plug right into the bladder? This can happen with conditions like spina bifida. In this case, you lose the contract signal almost completely. The bladder becomes underactive or flaccid. It just can't squeeze to empty itself, and that leads to chronic urinary retention, where urine gets stuck inside.
So, with all these different ways the system can fail, how on earth do doctors figure out what's really going on? Well, that brings us to Section 3, finding the fault line.
When doctors start their investigation, they have some really clear goals. Job number 1, always, is to protect the kidneys from that dangerous high-pressure damage we talked about.
After that, it's all about minimizing complications like infections, and then finding a management plan that actually works for the person's life. You know, taking into account their mobility, their hand function, even their cognitive abilities.
Symptoms alone can be super misleading. That's why for patients who are at high risk, there's a crucial test called urodynamics. You can think of it like putting the bladder on a stress test machine. It literally measures the pressures inside as the bladder fills and empties, showing doctors exactly what the muscles are doing in real time. It's really the only way to be sure about dangerous conditions like DSD.
Okay, so once the problem has been pinpointed, what can be done about it? Let's move on to our final section, restoring control and quality.
Often, the first line of defense is behavioral therapy, and this can involve some really simple but surprisingly effective strategies. Things like timed voiding, which is basically just emptying your bladder on a set schedule, whether you feel the urge or not. For some people, pelvic floor exercises can also help, as they can actually strengthen the brain's ability to tell the bladder to calm down and suppress those unwanted urges.
Now, if behavioral changes aren't quite enough, medication is usually the next step for an overactive bladder. And there are two main types, but they both have the same goal: to relax that overactive bladder muscle. The first group, anticholinergics, works by blocking the contract signal. The other group, beta-3 agonists, works by boosting the relax signal.
And for really severe cases of overactivity that don't respond to pills, there's Botox. Yep, the same stuff, but it's not for wrinkles here. When it's injected directly into the bladder wall, it goes right to work at the nerve endings. It basically gets in there and breaks a tiny protein that's needed to send the contract message. By blocking that chemical messenger, it effectively silences those overactive signals for months at a time. Pretty amazing, right?
Okay, but what about the opposite problem, when you can't empty the bladder? Well, the gold standard here is something called clean intermittent catheterization, or CIC. This means using a small, clean catheter to empty the bladder on a regular schedule throughout the day. It has way fewer long-term complications than an indwelling catheter, that's one that stays in all the time. Those are really a last resort because they come with a much higher risk of infections, stones, and other serious issues.
And this quote right here really sums up the entire philosophy of treating neurogenic bladder. It's a two-part mission. Part 1, protect the kidneys, do no harm. Part 2, do everything you can to improve or at least maintain the person's quality of life. Every single treatment decision gets weighed against those two fundamental goals. And this brings us to a final, bigger question to think about. Medicine is advancing like crazy. We've got high-tech nerve stimulators, advanced drugs, complex surgeries. But at the end of the day, managing a chronic condition like this is all about the daily reality of a person's life. So the question is, how do we make sure that all our incredible medical technology always serves the most fundamental human goals: comfort, independence, and dignity? It's something we're thinking about. Thanks so much for joining me.